Low libido is a really common experience that a lot of women have, especially during perimenopause and menopause and beyond. And unfortunately, it is not talked about nearly enough, including women's desire, pleasure, ability to experience pleasure, and their genital health in general. That's why this week I talked with Dr. Christine Vaccaro, who is a urogynecologist and women's sexual health expert, to really dive into what is driving low libido, what factors are playing into this, and what can we do to get that fire going again and really feel our best in our body. We'll explore how physical, hormonal, and emotional factors influence our libido and our ability to experience desire, and some practical, science backed ways to really rekindle the connection and feel pleasure again when things have just not been feeling right. Dr. Vaccaro, thank you so much for being with me today.
It is my absolute pleasure.
So, I always love to start with learning a little bit more about you, just how you came into your specialty, because usually we have a pretty good story behind that to learn more. If you can tell us a little bit more about that.
Yes. So I am a subspecialty gynecologist called a urogynecologist. So that is quite the journey. And I had the lovely pleasure of having a wonderful mentor I met in medical school who was a urogynecologist. And his name is Jeff Clemens. And he got me so fired up about women's quality of life that it made me pursue, I was going to actually go into urology, and it made me pursue OBGYN just to go into the specialty of urogynecology. Can actually go into it from urology as well now, but at the time that was like the main way to do it. And in my urogynecology fellowship, I had a faculty member that really got me fired up about women's sexual health because that is a very much overlooked area, gray area in medicine, and started studying the clitoris and clitoral anatomy because that was also a very under researched area, huge quality of life area for women. So currently my practice is mostly sexual medicine and urogynecology together. So I always tell patients, think of me like a quality life gynecologist.
Yeah, so I love
Yeah.
that. It really is such an underserved area. So I'm so glad that smart, capable doctors like you
Mhm.
are, feeling passionate about this from early on and able to go into that specialty because I think it is one that a lot of people don't know about. Even a lot of doctors probably are like, "Oh, I didn't really know, think about that." So it's
Mhm.
amazing that you're able to be that support and that quality life, supporter for so many women. That's so amazing.
I say I thrive in the taboo topics,
I
so
love it. Yeah. Well,
yeah.
some of these taboo topics are silly. Like they should not be so taboo. And the fact that they're
Mhm.
taboo are hurting a lot of women
Mhm.
and, even, impacting their not only their quality of life, but their livelihood altogether. So it's important to talk about, I think.
100%.
Well, today we're kind of focusing on libido. I think low libido is a really common complaint or concern that I hear from a lot of my patients, especially in their 30s and 40s. And it's
Mhm.
one of those ones, probably because it is so taboo, it sort of sneaks into the conversation, or maybe I directly ask about it and they're like, oh, yeah, I really don't have any libido. Or they're kind of concerned. They're like, this isn't impacting my relationship. Or they're
Mhm.
not sure. They're like, I don't know if this is normal or not. And there's so much confusion about it.
Mhm.
So could you kind of walk us through maybe like what's the starting point? Where do we start to think if someone is experiencing low libido, what are some things that we should be thinking about?
Yes. I love this question, and I could talk a whole hour on this topic, but I will try to break it down to the nuts and bolts. So when I think about libido, which is a biopsychosocial issue, so bio meaning biology is hormones, neurotransmitters, potentially sexual pain, anatomy concerns. So there's a whole bunch of groupings of what could be going on biologically, but then also really importantly is the psychosocial factors, which is stress, partner relationship issues, aging parents, children that have special needs. Currently going on right now is a lot of people losing their jobs in the government. I live in the DC area. So all of the psychosocial factors also certainly play into libido. We know by studying women, which we have at least some studies on women and libido, that it usually affects women in midlife, meaning from 40 to 60. And during this time frame, obviously there's a lot of hormonal changes going on with perimenopause and menopause, but also significant life stressors, again, aging parents, children, jobs. So it's a lot going on for women during that transition, and that's generally where libido just takes a hit and is just not a woman's priority
Mhm.
hormonally and with all the stress that's generally going on in their lives. So I try to, with a very thorough history and physical, get down to the biopsychosocial issues, and then really try to prioritize where do we start? Do we start with the psychosocial? Do we start with the biology? And sometimes it's a mix of both. Um, but really, it goes down to that structured sexual health questionnaires and history to really drill down on what is the issue. If you don't ask the right questions, you're never going to get to the bottom of it. And for some patients, it's some sort of trauma in their life. And I'm not just talking about sexual trauma, but religious trauma, right? Or is there some sort of medical trauma? Like there's so many things to tease out to really, and every woman obviously is unique and individual, and needs an individualized plan of care.
Mhm.
With saying all that, I cannot underscore enough the importance of hormones. And that is not just estrogen and progesterone, which we think about in women in menopause, but also testosterone, which is a really important human hormone that women have more of than estrogen at all time points in their life, except when they're really pregnant, when then estrogen is a little bit more. But it's a really important human hormone that also sometimes doesn't get enough discussion. So we do, in my practice, talk about testosterone a lot because, again, it's an important human hormone. So I'll pause there.
Yeah. Well, yeah, I mean, there are so many factors that play into it, sounds like. How much, because you're talking about hormones, how much of an impact do hormones play? Maybe when someone does have several factors going on, how much weight do we put on the hormones?
Mhm. When I hear a woman say in the last couple years, I've started having terrible sleep, hot flashes, night sweats, my vagina hurts, it's dry, I don't feel like myself when all that is happening. And then, oh, by the way, the last thing I want to do is have sex because I'm tired and I'm cranky and I'm irritable and I'm sweating and my vagina hurts, etc.
Mhm.
It's no wonder they don't want to have sex. They're feeling terrible. Their body's going through a catastrophic castration-like event happening with their ovaries. So I think a lot is going on hormonally, and if we don't support a woman enough, again, there's hormonal options, there's non-hormonal options to help with all the symptoms, then we're not probably going to address the libido fully
Mhm.
with psychosocial counseling, right? Which
Mhm.
is often a part of it, but generally not going to fix all of those biology factors that are happening.
Mhm. Yeah. How do the hormones actually impact our biology? And like we don't have to go like deeply
Yeah,
into it, but maybe to like ask because women are gonna be asking, well, how do the hormones actually impact it? Like
yeah,
what is the
totally. And I have a really busy slide I usually show, but
Mm.
it basically shows if you just picture desire as the center and then everything that's impacting it biologically. We know estrogen and progesterone directly support libido, and most of that probably is through, again, feeling more like yourself, meaning
Mhm.
if you're exhausted and tired and feeling terrible, if women aren't sleeping well, libido is like, again, they want a nap or they want to eat something because they're trying to get more energy, but the last thing they want to do is expend more energy on
Mhm.
sexual activity. So
Mhm.
again, I always think about sleep as the sort of the foundation. So do estrogen and progesterone directly impact it? I don't think it's like a direct. I think it's a can I support my body and feel more like myself?
Mhm.
Although we do have some interesting studies in like um, mice models where if you take out the ovaries of mice and then replace with estrogen, they actually are more receptive to sexual activity. But if
Interesting.
so, so it's
Hmm.
so estrogen basically makes women more receptive to their partner, but it's not going to be the spontaneous desire
Mhm.
that we get with testosterone, which I'll talk about in a second. So think of estrogen as okay, I don't have the spontaneous desire, but if my partner approaches me, I'm into it. I'll be
Mhm.
into it, right?
Mhm.
That's the receptive desire. And that's what estrogen does.
Mhm.
Okay. Progesterone, again, I think of that more like, again, helpful for sleep and anxiety reduction. And again, it just gets another building block of making a woman feel more like herself. And then there's testosterone, which sometimes we call the party drug, which is just basically meaning, right? For men, we know that testosterone works for libido. It helps for overall sense of well-being, optimism, energy, elevated mood. It also helps metabolically, right, with muscle support. So all of those things that it does for men, which we have a lot of data on, and most things in medicine, we have a lot of data on men that we extrapolate to a woman.
Mhm.
We know that probably help for women as well. However, the only data we have on women is really surrounding libido, but we have excellent data showing excellent safety and efficacy of using systemic testosterone for women if they're having low libido. Again, that gives back a woman those spontaneous thoughts and fantasies and the drive that usually she's wanting. I hear every single day in my practice, I just want sex again. I just want to have that idea that I might want to pursue it
Mhm.
versus this feeling of, well, I should be wanting it, you
Mhm.
know? So one of my other colleagues, Dr. Kelly Kasperson, a famous quote is don't should on yourself, right?
Mhm.
But women should on themselves all the time. I should be wanting and I should be this, I should be that, right? So it gives back libido through testosterone, gives back that spontaneous thoughts and fantasies.
Yeah. Amazing. And so it sounds like to also kind of answer a question that I commonly hear, or like a thought that people have, maybe they're not actually asking, like, is it normal? Like, is it just a normal retreat of, libido going by the wayside? And it sounds like, I mean, maybe to a degree when those hormones go, but it doesn't have to be like it, you don't have to just like it's all shut down now and no more intercourse for you. It can be something that is sustained
Right.
nicely.
And I think it plays into what's important in the relationship, what's important in the time frame of the woman, and where her partner is also, right? A lot of partners, neither one is really sexually driven, and they're matched well, right?
Mhm.
So then there's no mismatch. Where generally I see women coming to me bothered about libidos when there's a huge mismatch,
Mhm.
where one partner, usually the male partner, wants sex more, and the woman has zero desire for various reasons we've already covered, and then it becomes a personal distress and a relationship issue.
Mhm. Yeah, definitely.
Um,
And that, of course, that can play into desire also, right? The
mhm.
relationship dynamics, and as you mentioned, all of those stressors in life too. With approaching those, I mean, how much do those impact? And do those impact biologically, or really just with our mindset and our, mental capacity?
Yeah, there's a really nice, it's called the circular model of libido by Dr. Rosemary Basson, which, just to take a step back, the Kaplan and Meyer sexual response curve was kind of like more linear, like, oh, there's libido and arousal and plateau and orgasm. It was like this model. And Rosemary Basson really looked at women specifically and asked, what is driving you towards intimacy? And very rarely was it spontaneous desire, right? The just like I would wake up one day just feeling like I want to have sex with my partner. Very rarely was it that, but usually it was more a desire to feel connected with their partner, a desire for intimacy, a desire for connection, and potentially a lot of other beneficial things happen when you're connected to your partner, whether that's again something helpful for the family dynamic, etc. So generally, it's not just one thing, but more this like circular model for most women. I don't know if I answered your question, but
Yeah, no, I think that brings up the really good point of, especially in a relationship dynamic. Yeah,
mhm,
I agree. I think a lot of women especially need more like emotional safety, emotional intimacy,
mhm,
that connection with their partner to then want more of that connection.
mhm.
And then it is also like opens up the safety to then have the sexual intimacy as well. So that's really
Exactly.
interesting to have that model. It sounds more like a more, male driven model versus a more female driven model too with those.
Yes. Yes.
Interesting.
Exactly. Yes.
Yeah.
Mhm, mhm.
And then with the stress piece of things, is that are there like physiologic pieces of that also with how our stress hormones are impacting things, or is it really more of just how a woman's feeling and able to just feel receptive and calm and open enough to it?
Yeah, I think stress obviously plays a huge role here. Again, that's part of the psychosocial things, but I want to just kind of caveat to what I said before. So we have, again, biology factors, hormones, and neurotransmitters,
Hmm.
which help support a healthy libido or can detract from that. And very commonly in our society, women are offered antidepressants for mood disorders, for hormonal changes, which there is an FDA approved antidepressant for hot flashes, night sweats. So, again, a lot of times these medications are added to the mix. And most SSRIs, examples are Prozac, Paxil, Celexa, Lexapro, etc., Zoloft, really decrease a woman's libido by two actually different mechanisms on that biology, hormonal, and neurotransmitter model. So, stress, yes, impacts it. And then sometimes when we have stress, we're offered something, right? An
Hmm.
antidepressant, which is super common to be offered. And then that even knocks us back another level, another rung. So it's like really complicated. Sometimes medications that we think are going to be helpful to reduce stress and anxiety are then, yes, stress and anxiety is then better, but also now libido is even worse off.
Hmm.
It's complicated, it's so complicated. And I don't think oftentimes in a lot of medical appointments, a woman is given enough information about what the antidepressant slash anti-anxiety medication is going to potentially harm.
Yeah.
And again, I'm not down putting mental health. Mental health is super important. And a lot of times these medications are absolutely necessary.
Mhm.
I think what bothers me though is when it happens during the perimenopause, menopause transition, and the woman has been crushing life up until that point. And then when she goes in saying, "Hey, I'm not sleeping well, all of a sudden my mood is off, I'm really irritable, X, Y, and Z, all the reasons right," instead of getting offered all the possible options, including hormone therapy, she's only offered an antidepressant.
Hmm.
That makes me upset
Yeah.
because,
Same. That is one of my,
yeah,
yeah, pet peeves, if you will, as
yes,
well. Be that, yeah, women's going in, needing more holistic support, holistic in the sense of let's look at all of the options, let's look at all the factors that are going on here. And right, it's great to have some support, but an SSRI alone is not, the
right.
best approach to it. And yeah, if it's impacting other areas of her life, then, making everything harder. It's
Hmm.
not good.
Not good.
Yeah.
I agree.
Are there other like medications in particular or other factors there that you see commonly that are impacting things, or are those the biggest
I,
ones?
d- I do. So another common one, and I love my derm colleagues, but another very common one I see because again, other things happen in perimenopause and menopause, like hair loss,
Hmm.
and then also adult acne can crop up because of imbalance of hormones. So oftentimes a woman is prescribed spironolactone, which is a medication often used for those conditions, and that is actually a testosterone blocker. So, therefore, again, we're having in midlife not only crazy fluctuations of estrogen progesterone, but this slow decline of testosterone, and then we get like a hit with a testosterone lowering agent, and that really tanks libido even more. And oftentimes, I see the double. I have the
Hmm.
antidepressant and the spironolactone. It's like no wonder your libido is crazy in the dumpster because you're
Yeah.
literally doing two different things to lower it.
Yeah.
So that those are the two really common things. Another very common situation not in midlife is oral contraceptive pills.
Hmm.
Again, I am all for women's reproductive rights, and I want a woman to have reproductive choice. But the oral contraceptive pill specifically also lowers a woman's libido. It's a little bit complicated, but it affects a protein globulin that binds to testosterone. Then testosterone can't be freely acting in the body, and it can affect a woman lifelong, even after discontinuing the oral birth control pill. And we don't educate women enough about that potential adverse reaction to oral contraceptive pills. And just because we have a moment here, I'm going to just say there's so many non-systemically hormonal birth control options that don't have those effects. So if you're not a midlife woman that's looking for birth control, talk to your doctor about non-hormonal options because those are really also safe, effective, and again, IUDs are non-systemically working, which also are wonderful for not messing up your testosterone and libido.
Yeah,
So,
such an important point because it's another one that is given out so freely and the side effects aren't talked about. And yeah,
mhm.
I've had so many patients come to me with, I mean, all sorts of side effects after a long-term use of birth control. And again, yeah, I completely agree with you. It's there for a reason. It's a great tool to have, but women should be better educated about the things that can come up with it, or just know, wow, like, yeah, the depression, anxiety, and low libido that you're experiencing could actually be from the birth control that you're taking every single day. So,
Exactly.
yeah, that's a really important point.
Hmm.
How about, we know that like there are the physiologic pieces with libido as well, like blood flow and things like that. Are there some anatomical things that we should be aware of when it comes to libido or be watching out for when we're kind of doing this checklist to make sure, we're addressing these different factors?
Yeah, that's a huge, potentially not fully explored area. I just finished a research project measuring the genitals of 100 women of all
Mm.
different ages and racial diversity. And it's fascinating the things that we haven't really fully described regarding changes in midlife of the genitals.
Mhm.
So it makes sort of sense. I think most people kind of get when you don't have enough hormone support to a tissue, the blood flow reduces. When you have loss of blood flow to the genitals, things start shrinking.
Mhm.
That term generally has been called atrophy, which just means less blood flow, shrinking of the tissue. That cluster of symptoms in a woman that is in the menopause transition is called the genitourinary syndrome of menopause, or GSM. But basically, what's happening is not enough hormone support, not enough blood flow. The tissue, specifically around the clitoris, the glands, and the labia minora, start literally shrinking, and fusion of the labia can occur, fusion of the clitoral glands can occur, and these sorts of things aren't really well described, I would say, in the medical community. Why? Because we don't study women enough.
Mhm.
But we're starting to get more education research out there about all the things that can change in menopause. So in my practice, we take extra time to look at the clitoris to make sure that there are no adhesions, to if there has been labial fusion or um, what we call resorption of labia minora, at least we look at that with the woman to let them know about changes that have occurred, and then try to help them hormonally support the tissue that they do have so they don't potentially lose any more tissue. Again, we still don't exactly know the purpose of the labia minora. So is this a catastrophic change? We don't know. But we do know there's a lot of nerve endings and sensation that
Mhm.
can be very pleasurable in the labia minora. So I'll stop
Yeah.
there.
Yeah, I was gonna say, as you were saying that, like those shrinking tissues, then that impacts the ability to have arousal then, right? If they're less sensitive, they're less, if they're experiencing more pain, they're not able to experience as much pleasure. That
Exactly.
maybe that doesn't impact their libido, but it definitely, I would imagine, impacts how much enjoyment they're getting from sexual intercourse, how much they are going to want it in the future.
For sure. If a woman is having sexual pain, it's like telling, I often make the analogy about a hot stove. It's like, how many times do you want to put your hand on a hot stove and do that repeatedly? Not very often, right? So if sex is painful, that directly impacts libido because people don't generally want to do things that are painful to
Mhm.
themselves. So I didn't obviously state it, but vaginal dryness is one of the main symptoms of menopause of the genitals. And again, it's lack of blood flow, lack of support to the urogenital tissues, but specifically the vulvar vestibule and the vagina become very thin and don't have moisture. And that becomes, some women describe it like sandpaper, just extremely dry and painful, like
Mhm.
cutting or splitting of the tissue. So again, who wants to have sex when it feels like that? It's not good. But again, we can restore the health of these tissues just by giving back local hormone support, which is safe in all women. And just one more comment, I think we think about male sexual function in the terms of blood flow, when the genitals, really all of our tissues are very similar in origin. We're all the same. We just look a little different. We're a little rearranged, but we get a visual sign for men when they have ED because of blood flow issues. We don't get that visual sign for women because our tissues are a little smaller and more tucked away, but it's still the same sort of engorged tissue. We're just not seeing it as much.
Mhm.
And when blood flow changes and we're not getting as much support to the genitals, women often experience difficulty with arousal, loss of genital sensation, and more difficulty achieving orgasm or having muted orgasms, orgasms that don't feel as intense or as pleasurable as they did before. So again, that goes to like, well, and I love Esther Perel. She's a psychologist, relationship psychologist, but she often talks about having a bad meal, right? How many women want to have a bad meal repeatedly?
Mm-hmm.
It's like, ugh, it was bad, either painful or just not pleasurable. Like, ugh, do I really want to have another bad meal? Like, no, right? No one wants a bad meal, right? So we have to prioritize a woman's sexual pleasure more and make sure she's getting pleasure. So she wants to continue the sexual encounters because it's actually really good and healthy to have a good sexual health for both partners. A
Mm-hmm.
woman can benefit and a man can benefit. But if we're not prioritizing her sexual pleasure, well, again, who wants a bad meal?
Yeah. Oh, I love that analogy because it's not like it's like gonna kill you to eat something, but it's just really disappointing, and you definitely don't want to go back to that
Yeah.
restaurant or wherever it is. Yeah, that's great. Yeah, and I feel like that's such a good point too because I don't think anyone it would be on anyone's radar of like ED for women. It's like, what are you talking about? That's not a thing.
No.
But as you said, it really is the same thing. It's just you can't tell.
Mhm.
And even like there aren't conversations really about women's like successful orgasms and how much pleasure they're getting at
Mhm.
all. So that's such a great point to bring up where maybe a woman, as they're teasing apart why they're not having interest in sex, maybe this is a big piece of it. Maybe this is like, the thing that's really holding them back. So that's really good to be aware of.
And we do have some limited data on using vasodilators similar to Viagra for
Mhm.
women. So there's I think there's more going to come out in the future. It's just not like it's not one for one like it is for men. Right?
Mhm.
It's not just a blood flow issue. It's generally a hormonal issue primarily. But then again, if that doesn't bring in more blood flow, then sometimes again, topical or oral vasodilators are not out of the question for women,
Yeah, that's great to
even
know.
though we don't have a lot of great data there. I think the data is emerging.
Mhm.
So
That's good. Yeah, and I was going to ask with that, like as far as treatment goes, I mean, from what all I ever hear from women is like this can be a miracle drug and so easy and so safe to do some topical hormones. What are the things that you're usually reaching for this in particular, for the atrophy and everything?
I love whichever hormone topically a woman's going to do routinely. So
Mhm.
I'll just preface it with that. All of the things that we have are going to work. It's just what are they going to actually do that's going to be easy for them to add into their routine. So my probably very most favorite thing is vaginal estradiol cream. Why? Because you can literally just put it on your finger and just rub it right into the tissue, right at the opening of the vagina and the vulvar vestibule, where I say all the actions actually happening, right? And rub it in just like you'd rub in hand lotion or face cream, like you rub it in till it's rubbed in, and that way it's not messy. You don't worry about transferring to your partner, which shouldn't be a concern anyway, because again, men also have estrogen just like we have testosterone. But again, some women are worried about transferring cream. They shouldn't be, but that is a concern I hear a lot. But again, if you rub it in and you're putting it right where it's needed, it generally works really well to help prevent UTIs and overactive bladder and vaginal dryness, and again, support the tissue. Next, I love Interosa. It's a DHEA suppository. It's a vaginal suppository. And what I love about that is it comes in a really nice coconut base
Mhm.
and melts nicely, adds a little bit of lubrication, and turns into estrogen, testosterone at the cell level. So it kind of coats nicely the whole entire vagina. There's other rings and tablets and inserts, but again, generally those stay in the upper vagina, which is not wrong. It's just that where all the action's happening is at the opening. So I try to target the opening. For some patients that are having severe vaginal dryness that's not responsive to estrogen alone, sometimes we also compound an estrogen testosterone gel that is applied right to the opening of the vagina called the vulvar vestibule, just to make sure we're getting both androgens and estrogens back to the tissue, because male and female genitals have a lot of estrogen and androgen receptors in the genitals.
Mhm.
So sometimes if just estrogen is not working by itself, sometimes we need to add an androgen.
Great. And Another common concern that I'll often hear from people is like, is that going to then raise my levels, or do I have to get like, do I have to be concerned about using too much?
Yeah. Yeah. So for estrogen itself, we have excellent safety data that it does not increase the blood serum levels of estradiol. So really it works just locally on the tissue, safe in all women, even breast oncologists are on board with vaginal estrogen in women with history of breast cancer. It is very, 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 very safe and effective, and actually reduces a woman's risk for other things like UTIs and all the complications, including kidney infections and sepsis and death that can occur from a UTI. So again, everyone's on board, I think, with vaginal estrogen. Because we don't have as much data on topical testosterone because there's not an FDA approved product for the vulva, and
Mhm.
we don't have as much data on that. But again, in the doses we're giving, it is very, very minimally absorbed. It is not testosterone replacement for the full body, even though we're putting it on the vulva. It is not a high enough concentration to raise the serum levels
Mhm.
of testosterone.
Great. I feel like that's probably very reassuring to a lot of people who have those concerns because we're still trying to weed out all of the fear around hormone
Oh,
replacement therapy in
for
general.
sure. For
So,
sure.
yeah.
Yeah. Mhm.
And with that too, it sounds like topical DHEA is so helpful. Do you ever use like systemic estrogen or, all the hormones in general, like DHEA and things like that, and see a difference in libido arousal as well?
Mhm. I don't recommend like oral DHEA, just because usually the adrenal gland is making plenty of DHEA. So giving extra generally isn't that helpful. I like to go directly to the hormone that it would be turning into, which is testosterone, if we're looking at libido specifically. But yes, if I think about the ovary as a stool, a three-legged stool, right? And if we have just estrogen and progesterone, we're balancing, but it's not great, right? We really need that third leg to make a woman feel really, really healthy and vibrant and alive, especially if they're having libido concerns. A lot of women have a robust testosterone even in midlife. So, again, not all women need testosterone replacement, but if we check testosterone and it's low and they're having libido concerns, it really is beneficial to add that third leg so the stool is balanced
Mhm.
and functional.
Yeah.
So yes, so oftentimes we're giving back body identical, which I like to call isomolecular, which is the
Mhm.
same exact chemical structure as your body was making. So isomolecular estradiol, progesterone, and testosterone to basically support the ovary, which is sadly not functional past menopause. There is a little bit of testosterone that's being produced, but again, it's generally not as much as it was in the 20s and 30s.
Mhm.
Mhm.
And how about, are there any like supplements or nutraceuticals that you've seen good evidence behind that you use in your practice?
That is a loaded question, but what I will say is the supplements I love the most are hormones. And when I
Mhm.
say that, what I mean is I don't really consider hormones medications in the same way as like, we think about blood pressure medication or, medication for diabetes like metformin. Like those are medications. They're not the same as our body's producing. So when I think about supplements, I'm thinking, how are we supporting slash supplementing our body's natural physiology? So for me, that is strongly in favor of hormones.
Mhm.
However, I have women come to me with a bag of supplements, and some
Mhm.
are taking 20 plus supplements a day because they saw something somewhere that said they should do the X, Y, and Z for all the symptoms they're having. And I get it. They're trying to find help. They're trying to get something that's going to help them. And I try to walk them off the ledge and bring them back to the idea of hormones. And then if we have some other micronutrient deficiency, whether that's iron deficiency, whether that's magnesium or vitamin D or something that is tangible that we can measure, then I think there's benefit to supplementation. But I am not like I do this brand of this or this brand of that. I think if we give the body back what it is not making because of aging and the natural processes, generally we're getting the best bang for the buck and the best support of the body.
Mhm.
But again, if a woman likes something they're taking and it's giving them a benefit, I am 100% in support of it. What always brings me caution and makes me pause is because pharmaceuticals aren't FDA regulated, how much interaction are we having with natural substances? Because again, we could be having a lot of interactions that we don't know about. We could have other toxicities of the liver or kidney that we don't know about
Mhm.
because of all the variety of different products that we just don't have enough information about. So that does a little bit make me pause.
Yeah.
Um, but again, things like vitamin D, which is actually a hormone, it's a hormone that can be made through the skin, through sunlight exposure, but also can be taken as a supplement. Again, it's actually a hormone. So again, hormones don't have drug-drug interactions. So I feel a lot better about things like vitamin D or essential elements like magnesium or iron that we are using to supplement potentially like patients that are vegan that aren't getting enough iron through their diet naturally. So again, I think of supplements where we actually need them versus taking 20 or 30 of whatever the latest is on social media, et cetera,
Yeah.
for a patient. Yeah.
Yeah. Yeah. There, for any concern people have, there will be, you know, many, many things on the market for it.
Yes.
And you're right. They're not FDA, tested. There are some great brands out there that are, making sure they have good
Mhm.
quality, but there are a lot out there that are not. And there are things on
Yeah.
Amazon that are counterfeit. So that people could be putting a lot of like literal garbage into their body with
Yes.
those. So it's good to have a little bit of hesitation or
Caution,
make sure,
yeah.
like really make sure that things are appropriate. Yeah.
Caution advised, and try to spot predatory behavior. And like I also feel strongly that women are preyed upon during this very difficult transition period from perimenopause to menopause. And it's again, they're looking for anything that's going to make them feel better.
Mhm.
And sometimes I just see predatory behavior that also bothers me
Definitely.
out
Yeah, I agree. Um, how about, like other things that could help? How is there an impact of like physical activity,
there.
mo certain movements, certain types of therapies
Mhm.
there can be helpful?
Yeah, I love all of that. So when I talk to women just about longevity in general and how to maintain your fitness and your function lifelong, I think about like my absolute foundation is sleep,
Hmm.
right? So I want to make sure they're getting optimal amount of sleep and the right sleep for them, right? Some people um, oh, I'm getting 7 hours. I'm like, okay, well, what do you need? And they're like, well, I need 9. Okay, well, then you need 9, right? So just
Hmm.
because you're getting 7 to 9, if you actually need 9, then you need 9. So I try to get them to understand the importance of sleep quality and duration to make sure they're supporting their bodies as most as they can. Next for me is nutrition. So making sure they're eating a wide variety of fruits, vegetables, proteins, trying to limit processed foods. Again, nutrition science is a difficult science, but I think we can pretty much all agree eating whole foods, mostly plants, which is actually I got from a book called In Defense of Food, which I love this book. And he breaks down all the nutritional science and he states at the beginning, eat whole foods, mostly plants. He goes through all of the nutrition science at the end. He said, like I said at the beginning,
Hmm.
eat whole foods, mostly plants. So again, trying to eliminate processed foods from the diet. And then next for me on the rung is exercise, especially strength training. And again, I myself personally really appreciate yoga because I can do strength training and stretching, and it's good for my brain all in one package.
Hmm.
But again, it's whatever a woman feels like she can do routinely. Again, exercise that a woman hates isn't going to be something she's going to sustain. So finding whatever activity feels good in her body, but focusing on muscle building would be preferable. And then, of course, sadly, the elephant in the room, which is always wine or cocktails. So I generally have a chat about trying to eliminate things that are going to be harmful. And unfortunately, alcohol is so prevalent in our culture. And it's really hard for people to untangle themselves from that because it's very cultural pressure. You want to sit down with a good meal and have a nice glass of wine. You want to go out for cocktails with your friends. Like, I totally get it. But it's going to potentially ruin your sleep. It's going to make you eat more of maybe not so great things. And we know that it's a toxin. And the Surgeon General has also said, hey, it's a toxin and it's a cancer causing agent.
Hmm.
But people cling to their alcohol. And I try to um, just educate on the toxicity of it, and try to fuel the mocktail movement, which
Hmm.
there are more options out there. So those are the kind of the pillars that I go to, and of course, all in the lens of preventative health screenings, et cetera, to really focus on quality of life and longevity.
Yeah. Fantastic. And I feel like that brings up such a good point of those foundations impact everything, including, your reproductive organs, your overall health, how good you're going to feel, how, open you are going to be to intercourse then if you're feeling like, well rested and, you have good fuel and you're not, hungover or whatever, like all those things
Yes,
really impact each other. So that's amazing to bring those up.
yeah, for sure.
Any other pieces that like as far as testing or things you mentioned, talking about all of these, physical and psychosocial aspects that could be involved, having a physical exam, questionnaires, anything else that is on your radar that people should maybe be thinking about or looking at too?
Um, I think if there's no wrong answer here. I think really a patient can be driven to get a lot of labs and just, there's literally, you can order lab panels for 500 things if you want. But I think just the general basic labs that we're due for general screening is usually adequate. Of course, there's new up and coming data about ApoE and lipo-B and all the new things that are coming out. And again, I think it really just boils down to right now we're at a crossroads of we're advancing some medical technologies quicker than our guidelines can catch up about what preventative health screenings we should be getting. But for me personally, I generally do check hormone levels when things aren't going well, meaning if a patient I think should be responding to hormone therapies and isn't, I want to know what's going on. Are they non-absorber? If they're concerned about their libido and we're thinking about testosterone therapy, we have clinical practice guidelines that we use to say, hey, we need to check a baseline. We need to also then make sure when we are giving you therapy that we're keeping in the female zone. So those are places I use labs to check hormones. Of course, if they haven't been routinely seeing their primary care doctor, I will also get A1Cs to check their blood glucose, and a TSH to check their thyroid. And again, other health maintenance screening, like, of course, mammograms and colonoscopies, et cetera. But as far as like doing a huge, gigantic lab panel, I generally don't do that. And I don't find that super helpful. But again, I don't think it's wrong if a patient's like, I want to know every possible thing that could be going on in my body. Again, body autonomy. And if your insurance pays for that or you don't mind paying out of pocket, I support your choices.
Mhm. All right. And how about, I mean, maybe to kind of like wrap up, and you've given so much great information here. What's maybe one thing that you wish that all women knew about libido, their sexual health?
Oh boy. Well,
Or a few.
man, so
We can't do.
I'm I don't I'm sure that not everyone can see this because this might be an audible podcast, but what I'm wearing is a clitoris. It's a clitoris necklace, and the reason I wear it is because most women aren't aware of how big the clitoris is, what the clitoris looks like, haven't looked with a mirror to look at their own genitals. So if you're a woman that's listening to this and you haven't looked, please get a hand mirror, take a look at yourself, find your clitoris. It is a woman's main area of sexual pleasure, just like the penis is the main area for a man. Most women don't know or have never been told how to maintain their vulva, which includes the clitoris. So I just share a story that I tell to all my patients, which is males that are not circumcised are always told to pull the foreskin back to make sure debris doesn't get stuck under the foreskin and attached to the pineal glands. Women that have a clitoris are never told anything about the clitoris, right? And all women have a clitoris, and aren't told, hey, you should make sure you pull your clitoral hood back while you're performing your just routine hygiene, whether that's in the shower, bathing, whatever, to make sure nothing else gets trapped under there. We see quite a lot of patients with clitoral pain because of debris called smegma, keratin pearls, hair, and other things that get stuck between the clitoral hood and the glands. And this is entirely preventable and causes them extreme pain, like having a grain of sand in your eye, that you can't get out, and also causes relationship issues. And in the study I mentioned before of examining over 100 women, we found clitoral adhesions, severe clitoral adhesions, in up to 20% of patients.
Wow.
So it's not like, oh, that's a really rare, weird thing. No, sadly, because women aren't given enough information about how to take care of their genitals. We don't educate women about their clitoris. It's like a non-issue. No one talks about it, and it's a really prevalent issue that can not just cause clitoral pain, but loss of sensation of the clitoris, less sexual pleasure, again, and then lead to potentially low libido, having that bad meal they don't want to have again, et cetera, et cetera. So,
Yeah. Yeah. Oh, that's such a great point. Yeah. It's so sad. I mean, I feel like that like the big takeaway here is just like, and most of us probably already know this, there isn't enough research on women. We don't talk about, how to care for our genitals, how to, know what's going on in our body as far as our cycle goes. It's all just so shut down. And so, yeah, I'm glad we're having this conversation. I'm glad there are more conversations being had about this to just inform women about their bodies. It is not a like dangerous thing to just have women feeling really good in their bodies and taking good care of them. Everyone will benefit from this. So, yeah, I appreciate you.
one, and I appreciate you inviting me on so I can help get the message out to women. So thank you for doing this podcast and for inviting me. And for women that want more information about anything I talked about today, I really encourage you to check out this nonprofit organization called Sexual Health Education Plus Foundation. It's a women's nonprofit that is really pushing the needle forward on women's sexual health.
So,
Wonderful foundation.
oh, great. We'll link that in the show notes to make sure people can find that. And anything else you want to share, like where people can find you? You mentioned you're in the DC area. If someone wants to
Yeah.
come see you.
Yeah, so I work with a wonderful practice, Dr. Rachel Rubin. She's a very prominent sexual health provider, a urologist. So I work with her practice just north of DC in Bethesda, Maryland. You can also find me on Instagram at Dr. Christine Vaccaro. Yeah, so those are the two ways.
Perfect. Well, thank you so much again, Dr. Vaccaro. This has been so enlightening. I think it's going to be so helpful to everyone listening. So I appreciate your time.
My pleasure.